Hello and welcome everybody to clinical cardiac and pulmonary physiology for anesthesia rotation at Lynchburg General Hospital and Virginia Baptist Hospital. My name is Carly Hunt. I'm going to be giving you a series of 5 video lectures for this rotation that you can review during the first week of the rotation to be able to be more involved with your OR teaching and learn more about what we do in anesthesia. So this lecture is based off of a chapter 5 from Basics of Anesthesia by Miller and Pardo. Hopefully you've done your reading. If you've done your reading, this will be review. And in fact, most of this will be review for all of you. So welcome. And what I'm going to try to do in this lecture is briefly review the material, sort of assuming that you have learned this before in your different programs, and then try to give you places in anesthesia where you can really see this physiology happen and hopefully generate some really great teaching for you in the OR with your preceptor. So let's get started. I'm going to break this into 2 parts. The first part will be the cardiac part, and the second part will be the pulmonary part. So we'll start off with the cardiac part. Okay, so anesthesiology is a fantastic field of medicine, and it is one of the few fields of medicine where you not only monitor and diagnose cardiac and pulmonary problems, you also give medications, interventions that affect change on these systems and fix problems in these systems in real time all day long. So that's really fun. And of course, understanding cardiac physiology and pulmonary physiology becomes really important because of those interventions. So, and one of the primary things that you'll see almost all the anesthesiologists that you'll work with monitoring and trying to prevent or treat is hypotension. And you might also ask, well, why the heck are we so concerned with hypotension? Well, hypotension is really very likely in anesthesia because almost all anesthetics cause hypotension. Spinals, epidurals cause hypotension, and a lot of things that happen during surgery can cause hypotension. So I think on this slide, I talk a bit on that there. We've got it's often a problem with anesthetic delivery. And the real reason we care about it is because it decreases perfusion to organ systems that are important. So heart, if you're not getting enough perfusion, you'll have ischemia. Brain, if you're not getting enough perfusion, you'll have a stroke. If you're, you have don't have perfusion to your kidneys, you'll end up not having functioning kidneys at the end of the surgery. So all these things that we really want to monitor and keep perfused revolve around preventing hypotension. And there's a lot of extra morbidity and mortality associated with periods of hypotension during anesthesia. So that's a pretty well documented thing. This slide kind of runs through a quick differential diagnosis for hypotension under anesthesia and some basic treatments for those. So you'll notice at the top of the slide, hypotension under anesthesia is defined as having a MAP, which is a mean arterial blood pressure less than 60. And it's talking about different causes there. So on this side closest to us here, it talks about spinal and epidural anesthesia as a potential cause. On the middle lower one, it talks about patient factors, sepsis, blood loss, potentially causing hypotension. And the third is anesthetics, intravenous and inhaled anesthetics causing hypotension. And it goes through some different treatments that, obviously treating underlying conditions, intravenous fluid boluses, and different medications you can use to treat hypotension during anesthesia. So I think this gives you a little bit of a idea of when you might see this and how you would treat it. So just sort of big picture, these are things when you see someone giving ephedrine or phenylephrine or fluid, you might ask, hey, why are you giving that? And you can probably put it in one of these 3 categories, okay? So that might help you understand some of the things that your preceptor is doing, things you're seeing in the OR, okay? So when you're looking at this, the main equation from a physiologic sense, we're going to step back for a minute and think about the physiology of hypotension. There's 2 factors that contribute to mean arterial blood pressure. It's systemic vascular resistance and cardiac output. Now, there's 2 more factors that affect cardiac output that then affect mean arterial blood pressure. But on this slide, I'm just going to start with systemic vascular resistance. And there's a lot of factors in and around surgery that can decrease SVR, and the primary one is almost all anesthetics decrease SVR. They cause vasodilation of the systemic circulation and a decrease in blood pressure. And so we're always trying to counteract and prevent those types of changes. You might also see it in sepsis or anaphylaxis. Reperfusion of organs. So say we clamp the aorta and you're not perfusing. When you take that clamp off, you'll see a inwash of metabolites from those ischemic organs and will cause hypotension. So these are all things to look at. And the treatment of SVR is easier to treat than decreases in cardiac output, in my mind. Maybe that's just me, but we have a lot of good things. We have fluid, we have pressors, we have blood. If we're losing blood, there's a lot of things we can do to help treat SVR, decreases in SVR. So there's that stage. Now, the next slide, we're going to get into how cardiac output contributes to MAP. And there's two pieces to cardiac output. You see at the top there, heart rate and stroke volume. And I know you guys know about this, so I don't want to go crazy about it. And generally speaking, if the stroke volume goes up, the cardiac output goes up, barring a valvular disorder such as a mitral regurgitation. There are some exceptions to all these things. And also heart rate. Generally, if the heart rate goes up, it increases cardiac output. Of course, extremes of heart rate can be exceptions to that. Sometimes if you slow the heart rate down, you actually increase filling in the left ventricle and increase your stroke volume. So you actually might have more cardiac output. And also cases where you have really rapid heart rate. You may also not have enough time to fill and not get a good enough filling and therefore enough stroke volume and thereby reduce your cardiac output. So a classic example of that would be like if you have someone that you have to do anesthesia on that has rapid AFib. They may not be feeling, they might be beating, their heart may be beating really fast, but yet they're still hypotensive, having low cardiac output and therefore low blood pressures, low MAPs, because the heart is contracting so fast that you would want to slow it down some that it can fill and pump the blood. And so that can be a great question to ask your preceptor. Like, what if someone is in rapid AFib? What would you see? How would that affect the cardiac output? How would that affect the blood pressure? And typically the answer is going to be something about slowing the heart rate down, okay? We're going to talk a little bit of stroke volume. And when we talk about stroke volume in clinical settings, it's really hard to measure it directly. So what we use is EF, which is an ejection fraction, and it measures it's a measurement taken off echocardiography. It talks about what percent of blood leaves the left ventricle after contraction after systole, and sort of a before and after volume, and then what percent is gone. And generally, if the heart's functioning normally, that should be a pretty good estimate of stroke volume. There are some valvular disorders that can change that. Mitral regurgitation would be the most common one, but that's what you'll see people use as a clinical marker of stroke volume. And there's three things that determine cardiac output and stroke volume. Cardiac output. So preload, contractility, and afterload affect stroke volume and thereby affect cardiac output and thereby affect MAP. And you guys probably know a lot about this. Preload is the filling of the heart, getting adequate fill of the heart. Contractility is the innate contractility of the muscle itself, which can be decreased from things like ischemic cardiomyopathy or increased by medications like epinephrine. And afterload is a lot like SVR. It's about how much resistance the heart is pushing against and during systole. So all these things can increase and decrease cardiac output and affect MAP. And you can oftentimes talk to anesthesiologists in situations about where you think one of these things might be low or high and how they're adjusting their anesthetics. So, for example, someone who is really volume depleted, either from blood loss or just dehydration, they might have decreased preload from just not being able to fill. And how does the anesthesiologist change what they're doing to fix that? You might have a patient that comes in with ischemic cardiomyopathy and decreased EF, contraction might be 15%. How do you change what you're doing to keep the heart pumping effectively and to perfuse the organs and maintain blood pressure? That's a really great question that you might want to talk about as you're going through your cases in your rotation. Then the cardiac reflexes, and first ones we want to talk about are autonomic reflexes, and those fall in two categories: sympathetic and parasympathetic. I'm thinking you probably talked about this somewhere along the way in all of your training. So sympathetic stimulation, you might remember, it raises heart rate, raises blood pressure. It's through beta-1 adrenergic receptors. It also increases myocardial contractility. Parasympathetic is a profound decrease in heart rate through activation of muscarinic acetylcholine receptors and may decrease contractility slightly. And you might also recall what parts of the vertebral column those autonomic nerves come out of. And you might remember that parasympathetic innervation is craniosacral, and sympathetic stimulation is lumbar thoracic. And this really comes into play when we're talking about placing a spinal anesthetic. So this is what this picture is all about. You'll notice there's a needle down here at L4-5 where we're injecting local anesthetic into the spinal fluid, and at the below the level of the spinal cord, and at base, it will begin to go up the spinal column this way. And the first thing you'll see is that it anesthetizes the autonomic nerves coming out of the lumbar segment, because that's where it's closest to when we put it in. And you'll see hypotension from decreased sympathetic stimulation there. And then, but you'll still see tachycardia because your sympathetic cardiac accelerators are in the higher segments of the thoracic spine. So you'll still see an increase in heart rate. And then once you anesthetize those lower thoracic T1, T3 segments, you'll see a decrease in heart rate. You'll actually have anesthetized those autonomic nerves coming out of the thoracic spine, and you'll see unopposed parasympathetic flow to the heart via the vagus nerve and the cranial nerves. So watching a spinal anesthetic set up is really interesting when you think about these autonomic reflexes and how they're set up. And so you can talk with that about your preceptors. You could do your presentation on something like that. It's really interesting stuff, and it relates right back to the physiology you've recently learned. The other type of reflexes we have are baroreceptors and chemoreceptors, and this is in the periphery, meaning carotid sinus, aortic arch. There are some baroreceptors in the atria and the ventricles to tell you about stretch and fullness of the atria. And so the main ones we think about, though, are in the carotid sinus. And when you're doing a carotid endarterectomy, this is a fantastic time to ask about baroreceptors. When the surgeon is working around the carotid sinus and he ends up mechanically manipulating the baroreceptors, you can have a baroreceptor response. And so if you're in a case like that, it can be really interesting to watch and see how the heart rate changes as it's mechanically touched. Normally, obviously, they work such that if the pressure goes up, it will stimulate an decrease in the heart rate, or if the pressure goes down, it'll stimulate an increase in the heart rate. But mechanically touching it during the surgery can affect your blood pressure and heart rate, and the anesthesiologist is expected to adjust their anesthetic when that happens. So those are some interesting things to talk about. And it's also interesting to note that all anesthetics pretty much blunt cardiac reflexes. So again, leading to more hypotension. You're going to see a theme here with the cardiac side. We're always thinking about hypotension and how we can prevent that and treat that. Okay. We'll talk a little bit about coronary blood flow and pulmonary blood flow, and then we'll take a break and come back to the pulmonary stuff. So cardiac blood flow is really interesting in that it already is maximally extracting oxygen from the blood. The only way to increase perfusion to the cardiac muscles, but the left ventricle, is to increase flow through the vessels. And so there's very little effective sympathetic of autonomics on this. It's all regulated locally through endogenous activators that are released at the level of the vessels themselves to increase flow where it's needed. But you'll find that the equation for this is reliant on blood pressure. So another great reason not to have a drop in the blood pressure is to maintain blood flow to the heart. It's actually diastolic blood pressure that's the first part of that equation for perfusion pressure, but it's still important. We're going to pause here, and I'll pick back up in part 2. Thanks.